This section of the Critical Care Survival Guide is going to focus on the use of vasopressors in the ICU. We'll start with norepinephrine, which is one of the most commonly used pressors in the ICU. Norepinephrine works on alpha-1 and beta-1 receptors. Alpha-1 receptors are located in blood vessels causing peripheral vasoconstriction. Beta-1 receptors are located predominantly in the heart, which causes increased cardiac output. For this reason, norepinephrine is used predominantly for sepsis, but is also an appropriate pressor for cardiogenic shock. Some recent studies have showed it may be better than dopamine in some situations because it has less tachyarrhythmias. For this reason, if you're not sure what kind of shock you have, it's reasonable to use norepinephrine first. The typical dose is 1 to 30 micrograms per minute. Let's move on. We'll talk about dopamine next. Dopamine works on similar receptors, alpha-1 and beta-1, and also has dopamine receptors scattered throughout the body. However, its effects tend to be more prominent on the heart at lower doses in the 1 to 10 mics per kilo per minute, and then you don't get the peripheral vasoconstriction effects until you're at higher doses of dopamine. This idea of having renally dosed dopamine is really been debunked recently, so there's no indication to use low dose 1 to 3 mics of dopamine to better perfuse the kidneys. Dopamine is used most prominently for cardiogenic shock, but it can also be used second to third line for septic shock. You have to be careful because of its effects on the heart. You have increased risk of arrhythmogenicity with dobutamine. So I tend to avoid it in patients who are significantly tachycardic or who have a significant risk for arrhythmias. Typical dose is 1 to 20 mics per kilo per minute. Let's move on and talk about vasopressin next. Vasopressin's receptors are actually specifically V1 receptors, so the effects are a little bit different, but these effects are located in the vascular and GI smooth muscle, causing vasoconstriction here, as well as powerful antidiuretic effects. Because of this, vasopressin is used almost exclusively in septic shock, and typically as a second-line vasopressor after norepinephrine. You have to be careful using vasopressin, especially in septic shock, because it does cause coronary and splanchnic vasoconstriction. So for this reason, I'll avoid vasopressin in the setting of NSTEMI. Typically with a troponin over 10 or so, I would certainly avoid it. Although if you have mild troponin leaks, that's reasonable to continue to use vasopressin. I also avoid vasopressin in the setting of gut ischemia. Typical dose here is 0.03 units per minute. This is a pressor that's not titrated. We'll move on to phenylephrine. Phenylephrine actually works purely on alpha-1 receptors, causing vasoconstriction in the peripheral blood circulation. It has no beta-1 effects, so it's completely cardiac neutral. For this reason, it's used predominantly in neurogenic shock, which is this distributory shock that has complete loss of tone of the peripheral vasculature, but it can also be used usually third to fourth line in septic shock when you have very refractory hypotension. Rarely you'll see a reflex bradycardia occurring with phenylephrine, but the good thing about it is it's relatively heart rate neutral and does not worsen tachycardia. Typical dose is 20 to 300 mics per minute. The last pressor that we'll talk about is dobutamine. Dobutamine works on beta-1 receptors. It has a significant increase in cardiac output resulting from dobutamine, and however, it does have a few receptors that it works on in beta-2 receptors in the peripheral vasculature. This actually counteracts the alpha-1 effects of some pressors and actually can cause a vasodilatation. For that reason, you'll increase cardiac output, but you may worsen hypotension when starting dobutamine. For this reason, dobutamine is used predominantly in cardiogenic shock, although sometimes we use it in low-output septic shock, and it is part of the surviving sepsis recommendations along that algorithm. Again, you have to watch out for tachyarrhythmias because of its beta-1 effects, and you have to watch out for hypotension. Typically what I do with this is if you're starting dobutamine for a patient with cardiogenic shock and their blood pressure drops, you may need to add a second pressor with some alpha-1 effects, such as dopamine or norepinephrine. Typical doses for dobutamine is 2.5 to 20 mics per kilo per minute. I will point out that this is one pressor that we don't ask nurses to titrate. So we pick a number that we want to set it at, 5 mics per kilo per minute, and have the nurses start it. And that way you can adjust it, but not have the nurses adjusting it on the bedside on the basis of mean arterial pressure. A few closing thoughts. You want to assess the cause of shock in all of your patients because depending on what the cause of shock is, this will change which pressor is going to be your first-line pressor. Consider norepinephrine for undifferentiated shock because this has beneficial effects in both cardiogenic and septic shock. Finally, next, volume resuscitation is the cornerstone of many forms of shock. Sepsis, neurogenic shock, distributed shock, all require volume resuscitation. The only time you wouldn't consider volume resuscitation first before starting pressors is in cardiogenic shock, and you may not always know that you're looking at cardiogenic shock when you start. So volume is always appropriate as initial first step before your pressors are started. Finally, all of these vasopressors we've talked about today are going to require a central line placement. This may also help you decide if your patient's wet or dry by checking central venous pressures. That concludes our discussion of vasopressors in the ICU. We'll see you next time.